Hello, everybody, and welcome to our continuing medical education series here at SunCloud Health. My name is Dr. Kim Dennis. I'm the co-founder and chief medical officer. We are an integrated treatment center offering IOP, PHP, and residential levels of care. We have a specialty residential unit for people with specifically co-occurring eating disorder and addiction, and another residential unit treating patients with any diagnosis, multiple diagnoses. We offer adolescent treatment and adult treatment as well. We're based in the Chicago area and are soon to be opening an office in Maryland. So, and if you're zooming in from the East Coast, we'll be in your neighborhood. I am delighted to introduce all of you today to Dr. Jean-Luc Cadet, who comes to us from the NIH. I feel like I'm in the presence of scientific royalty and extremely grateful that Jean-Luc, that you came here today and are going to be talking to us about methamphetamine use disorder. Dr. Cadet is presently an NIH tenured senior investigator and the chief of molecular neuropsychiatry research branch and of the molecular neuropsychiatry section at NIH and NIDA. He did medical school at Columbia University in New York, subsequently did a psychiatry residency at the Department of Psychiatry in Columbia, and a neurology residency after that at Mount Sinai Hospital in New York. He graduated from his residency program when I was 8 years old and has dedicated his career to research, brain research. He's authored more than 500 papers, reviews, and book chapters on the molecular biology, the neurobiology of substance use disorders. He is a reviewing editor for scientific reports and associate editor of Frontier in Public Health. He's a member of the Society for Neuroscience, ASPET, National Medical Association, Black and Neurotoxicity Society, the AMHE, the Society of Haitian Neuroscientists, and has received several awards, including the NIH Directors Award, as well as visiting professorships, including the Grass Foundation Lectureship. And I just want to share one of the quotes from Dr. Cadet's emails. If any of you get emails from Dr. Cadet, the quotes are really amazing and worth sharing here. Ignorance coupled with power is one of the most ferocious enemies of freedom-seeking souls. And that's from a neuroscientist. So without further ado, I will let Dr. Cadet teach us all.
Thank you for the nice introduction. Thank you for the, actually, the nice talk before this. So we went over time talking about my life story. So as you can see here, today I'm going to be talking to you about the epigenetic and neurotoxicity of methamphetamine addiction. And then this is really important for us as a subject, as clinicians and researchers. So there are still a lot of people using methamphetamine, but if you listen to the news, it is as if everybody in the country is only using opioid and dying from fentanyl. In actuality, there are a lot of people using drugs, methamphetamine, and the death from methamphetamine has increased significantly. And but the problem, in the case of opioid, we have some medication that we can use to treat patients, but for methamphetamine, there's no FDA-approved medication. So as clinicians, we should also keep in mind that there are sex differences in terms of presentation, clinical presentation of patients who suffer from methamphetamine use disorders, with men most likely to die from overdoses and women suffering more neuropsychiatric complications of methamphetamine. And I will be talking about some of those later on. So there's some diagnostic problems associated with misdiagnosis. A lot of people who are using methamphetamine delay seeking treatment, and when somebody is using methamphetamine and they have the other psychiatric diagnoses, they're less likely to respond well to medications like lithium in the case of bipolar disorder, and they actually show a lot of rapid cycling because of the way that methamphetamine works in the brain. So in the rest of the talk, what I'm going to do, I'm going to talk to you about methamphetamine use disorder, talk to you about a model of meth use disorder that we are using in my lab at the NIH, and we'll talk about the dopamine system, and towards the end, we'll talk about how methamphetamine can cause epigenetic changes in the brain. So historically, methamphetamine was first synthesized by a Japanese chemist, Akira Ogata, and methamphetamine is being used clinically, as you know, for a number of clinical diagnoses. But the one thing that's interesting that a lot of people don't know about is that methamphetamine during the Second War was used by all of the armed forces, like the Allied forces, the Nazis, the Japanese. And then after the war, there was so much methamphetamine in Japan that the methamphetamine was dumped on the Japanese populace, and that was the first wave of methamphetamine use disorders and psychosis associated with that. So this is the structure of methamphetamine. As you can see here on the left side of this presentation. And then, so one thing I should want you to keep in mind is the similarity of methamphetamine with dopamine, right? We all know that dopamine is very important for a lot of psychiatric disorders. But so that tells you that when you're taking methamphetamine, basically you're increasing the amount of dopamine that you have in your brain. So right now, the only really good clinical use for methamphetamine is for kids or adults with attention deficit disorder. It shouldn't really be used for any of these other clinical problems. So this is the way methamphetamine works. So methamphetamine gets into the brain very easily, right? It's very liposoluble, and when it gets into the brain, it gets accumulated in the vesicles that contains dopamine. And when it gets accumulated in those vesicles, it displaces dopamine. So you can get a lot of dopamine in the synaptic cleft. I hope you remember a little neuroscience that you took. So the cleft, dopamine goes way up. But when dopamine goes up, it binds to like dopamine D1 receptor, D2 receptor. In the case of patients who have psychiatric diseases that have problems with the D2 receptor, you can have all this secondary effect. That might be one of the reasons why we have this complication when patients with bipolar disorder, schizophrenic, take methamphetamine. So in one of the studies that we did, we wanted to compare what happens to dopamine in the synaptic cleft of rats. So we gave methamphetamine to the rats. As you can see here, we can give 10 milligram or 20 milligram of methamphetamine. And so you have this huge increase, about 6,000% increase of dopamine in the synaptic cleft of the rats. If it were cocaine, all you would have is about 500-fold increase. So you can understand why some patients who are used to be cocaine users switch over to using methamphetamine, because the high they get from methamphetamine is so much better for them, bad for their brain. And let's talk a little bit about the meth use disorder in the clinical presentation. So when somebody takes methamphetamine, almost immediately they get euphoric, right? That's why they take the drug, and they get high. But there are a lot of clinical complications associated with taking the drug, and one of the worst one is hyperthermia, as you can see up there. And the reason why people die when they overdose is because of the hyperthermia. And when I give talks like this to young people, I almost always remind them not to give a lot of water to their friends who might have been taking ecstasy or methamphetamine to reduce the temperature, because that can cause SIADH. So you should keep that in mind. Also, if you have somebody who comes, you don't have emergency room, right? But if you're working in an emergency room and somebody presents, dump them in an ice bath. Don't give them any fluid. It's by mouth. So that, with SIADH, their brain's going to swell and they're going to die faster. And then they go through these benches on the weekend, and they don't stop until they run out of methamphetamine. But the biggest problem is the crash, right? They run out of drug, they crash, they become depressed. And some people have committed suicide, right, because they get so depressed from the methamphetamine. And the craving is what drives people back to using the drugs, right? So it's something that in psychiatry we have to really try to figure out how to best treat people who are craving drugs. We really don't have a good handle. Okay, how do you deal with the intense craving that people suffer from? So just again to remind you of the structure of the brains, the ventral tegmental area, VTA, is where all of those dopamine cells that are impacted in schizophrenic patients, in manic depressive patients, it's those circuits. We were talking about that, are really important, not just to addiction, but a lot of other diseases. That's why we have these co-occurring disorders presenting in our emergency room, in our clinical practice. So the VTA has this projection that go to the prefrontal cortex, to the hippocampus, to the nucleus accumbens, to the amygdala. So this, whenever you see somebody in clinic, keep this circuit in mind, because the way you address different aspects of what patients are presenting with is really going to be dependent on which one of the circuits are being impacted at the time. So this is a summary of what happens with when people take drug. They take an initial dose, they escalate their intake, and they then go through these binges and abstinence. They withdraw, they crave, and then they relapse, okay? So I have this in my mind all the time, try to say, okay, what are the different mechanisms at each stage? Where do you want to catch people to try to develop treatment for them? And in our studies that we do in my lab, I actually address the issue that way, okay? And I'll talk about that a little bit later. I'm talking as if everybody who takes methamphetamine becomes addicted to it. You know that's not true, right? There's some people who still can stay recreational users for a long period of time, while there are others who become users of high dosages of methamphetamine, and those patients tend to use it by smoking and inject. Most of the people who overdose, they overdose through injections. So the other thing that I should tell you is that methamphetamine users, those that are using high dosages, have been shown to have abnormalities in their brain. So that's one of the issues when you have these patients in treatment. Their brains have been impacted by the methamphetamine. As you can see, those have been done in live patients using PET studies, where they've shown abnormal glucose metabolism in a lot of different brain regions, and then loss of dopaminergic terminals in the dorsal striatum, And then postmortem studies of people who have overdosed have also shown that there are abnormalities in the dopamine system mostly. And this is a study by the director of the NIH, Noah Volkow. On the left side, I think left side, you see the normal brain, and then the red, really bright red, is dopamine terminal, the number of dopamine terminals. And on the other side, you see the brain of a meth user, where you see the red is really much paler, right? So they've lost dopamine terminal, and this is live patients, right? So somebody's coming to you, keep in mind that meth addiction is really is a brain disorder. So when you see a patient, any patients that you see, not just meth users, remember that psychiatric patients can have medical problems, and they also can have neurological problems. And I loved, when I was a resident at Columbia in the 1980s, when she was only 2 years old, I used to try to remind the neurology resident when we called for consult that these patients can have neurological problems, and then they needed to get their presence when we called them for neurology. And then the good thing about this is that I knew the chairman of the Department of Neurology, because I would have really said to them, if you don't come, I'm calling your chair that you not. So they say, why are you calling the chair? I say, because I know who he is, and I know him. If you don't come and do the consult. So always keep in mind that in the case of meth users and schizophrenic patients or other patients, that their brain can be affected, but they can also have medical problems. And then make sure that whatever clinical symptom they're presenting with is not dependent on some medical neuroimmuno disease that might be causing the psychiatric symptoms. So now we go back to the startup studies that we are doing in my lab. So as you know from reading the DSM, that compulsive drug use or cocaine use disorder, opioid use disorder, meth use disorder, they are characterized by loss of control over the drug that they're using. They compulsively use the drug. They continue to use the drug despite adverse consequences. That's a major, major problem, right? So if you're a young person who's using alcohol in college, so I'll tell you a story about that. My son came to college in Chicago, and then after he was there for a few months, he called me and said, Dad, all the kids here are alcoholics. And I said, wow, they might be using alcohol, but they're not necessarily alcoholics. Yeah, because what happened is that most of them, when they're finishing college and they know that they're going to get jobs, or if their family members say, mother and father say, okay, if you don't stop drinking too much, I'm not going to pay the tuition, they'll stop, right? And which I had to explain to my son. I say, well, you know, wait until they have to apply for a job. The vast majority of them are going to stop. So adverse consequences really control what happens. And the craving. So we talk a little bit about craving in terms of needing better way of dealing with craving for these drugs. So related to that, you can see here on this figure that for nicotine, only about 24% of the people who actually smoke meet criteria for substance use disorder. Heroin is about the higher, based on that study, the highest percentage is about 38%. Marijuana, only 9% of the people meet criteria. But when you come to methamphetamine, between 40 and 50% of the people who use methamphetamine meet criteria for SUD. But in the preclinical literature, most of the people who are doing the studies, they use all of the animals and they try to develop theories, right, based on the brain of all of the animals that they taught to self-administer drugs. So we thought this was wrong, and so we wanted to address it. So one potential approach to this, to mimic adverse consequences, is to use punishment. Okay, you can do that with rats, and then to represent the adverse consequence criterion of the DSM. So some people had done this with alcohol and cocaine and show that you can differentiate animals that are what they call punishment resistant and punishment sensitive. So we wanted to see if we could do it with methamphetamine. So we can train rats. Okay, you can see on the left side of the box for different days. So we train hours, usually 20 to 21 days, sometimes a whole month, to give themselves methamphetamine, right? You can do it with cocaine. Rats don't like doing it with marijuana type drug. THC, they just don't like self-administering THC for some reason. But they'll do it with oxycodone, heroin, cocaine, methamphetamine, the more addictive drugs. So rats really love methamphetamine. And they learn to give themselves methamphetamine very quickly. And I'll show you some figures showing that. But then we apply the food shock. So that's the mother or putting the rats in prison and see if they keep giving themselves methamphetamine. And then, so we apply different intensity of the food shock and then see what happens. And then we stop, and then we do some tests related to craving for the drug. So this is the first study we did. So you can see the rat will progressively give themselves on the A, they'll progressively give themselves methamphetamine, and then in C, we apply the food shock. You can see the intensity. Some rats, the open circle, will continue to give themselves methamphetamine despite the food shock, right? And some other ones in black, they'll suppress their intake of methamphetamine, right? So that's the kids whose parents are saying, we're not going to pay your tuition, you cannot come to visit, you're not going to go to the vacation on the ski slope somewhere in Europe, which I never. So there's a story about that. So I have to say it. My first year in medical school at Columbia, so I lived in Brooklyn, but I was in school in New York. All the kids were going to ski slope, and I had to go to Brooklyn. I couldn't take any vacation. I said, wow, I'm the poorest kid in class. But anyway, so when you came towards E, what we also were able to show was that the rats that actually continue to take the drugs, they crave methamphetamine much more than the animals that didn't, that suppressed their intake. Because we know that methamphetamine works on the dopamine system, we wanted to know if we could interfere with drug self-administration, methamphetamine self-administration, by attacking the dopaminergic system. So in this experiment, we did the same thing. We set up the self-administration for 20 days. The animals, as I mentioned before, they love methamphetamine, so they take a lot of methamphetamine. And then we use this drug that blocks the D1 receptors. You remember the D1 type receptors, D2 type receptors. The D1 type receptors are D1 and D5, and the D2 type receptors are D2, D3, D4. So we use a compound that actually blocks both the D1 receptor and the D5 receptor. So to see what would happen if we gave the animals this drug. That's not used clinically, it's just an experimental drug. So you can see where the food shock is. So we have the red that continue to take methamphetamine despite the shock, okay? And then the blue that decrease their intake of methamphetamine when we apply the adverse consequences. But when we give the SCH drug, SCH-22390, which is a D1 antagonist, the red animals, right, the drug-addicted animals, the compulsive users of methamphetamine, they decrease their intake, but we're not able to completely block the methamphetamine self-administration, which told us that there were other receptors, whether dopaminergic D2 type receptors or other glutamate receptors, because people have suggested that glutamate system is involved in methamphetamine addiction. They were never able to get them to the level of the blue animals. And then so when we stopped the D1 antagonist, the animals went back to using drug, right? So, which is, patients will do that, right? You have the medication, they stop their medication, they go back to using drugs, they're getting depressed. So you remember we'll do tests to see how the animals will relapse, and then the red animals are the ones that are addicted to methamphetamine, and then over time, the animals tend to crave methamphetamine. And then you can see the red ones, they're craving a lot. They're pressing the lever trying to get methamphetamine, but we're not giving them methamphetamine. And then the blue animals, they don't press the lever as much. So the more addicted the animals, the more they crave the drug, which is very similar clinically to what we'll see. As we talked about, you remember I showed you the picture of the brain with the projections. So I gave it more like a cartoon here. So you see the projection of the VTA to the hippocampus, to the nucleus accumbens, to the, and then to the prefrontal cortex. But also here I put the substantia nigra pars compacta. A lot of times when you're talking to scientists or clinicians who are doing clinical research, they really just focus on the projection of the VTA, the ventral tegmental area. But our ideas is that the substantia nigra projection that projects the dorsal striatum is very important to addiction because it's related, addiction is related to habit forming, right? So when you talk of, I lived in New York, as I've told you before, and then I spent a lot of time in Manhattan around people who were using drugs when I was younger in jazz bars and other places. So when you talk to people who've been using drugs for a long period of time, the high that they experience at the beginning is not there, right? And so it becomes really the habitual, right? So how do you break that habit? So we've been focusing a lot of our work looking at the dorsal striatum, even though we also look at the nucleus accumbens. I'll present some data related to that. So what we wanted to know was what happened to the dopamine system in the dorsal striatum in these animals that I just showed you the behavior of. So this is the, oh God, this is the dopamine system. I want you to remember it because she's going to test you afterwards. Not me. I don't test people anymore. Anyway, so, but you've heard of oxidative stress. I've written paper about schizophrenia and oxidative stress. So dopamine, right? Dopamine is great, make us happy, but dopamine is also really bad. As we age, the reason why we all slow down, you can see I'm really slowed down, I'm walking like this, is because we've lost dopamine in the dorsal striatum. The reason why we lose this dopamine over time is because dopamine itself is killing the cells that contains it, right? See, and you're thinking, oh no, dopamine wouldn't do that, but yeah, dopamine do it. And dopamine is neurotoxic, right? So, and it really causes neurodegeneration. In not only the dopamine neuron themselves, but they will attack cells that are postsynaptic to it. And we've shown that methamphetamine can do that, and I won't show those. But most of the neuropsychiatric, neurodegenerative disorders like Alzheimer's disease, amyotrophic lateral sclerosis have oxidative mechanisms that are involved in their manifestation. So we measured dopamine level in the brain of these animals, and you can see dopamine there, And so in the brain of this animal, there was a reduction of dopamine in both the compulsive users and the non-compulsive users. That was about 30% reduction. So we kind of say, oh, yes, that's what we expected. So that told us that even in the animals that don't become addicted, if they've been exposed to methamphetamine long enough, to a high dose enough, their brains are being impacted, right? So when you have patients who are using methamphetamine, one of the suggestions that I make is, because of the oxidative stress that they're facing all the time, is to use antioxidant together with whatever other treatment program that you might have them in. So we've done other studies in the past, and we've shown that the dopamine levels are down, serotonin level are also decreased. The important thing, though, is the third down, where we show, just like Nora Volkow showed in her study with human, that the transporter system are also impacted. The transporter system that takes dopamine back into the cells and help them to sequester dopamine, because when dopamine is in a synaptic cleft, it's causing damage not only to the cells that make it, but to the cells that are postsynaptic to it. So, so we wanted to know what happened to the dopamine transporter. So here, if you go where it says VMAT2, right, and that's the vesicular transporter that the vesicle sequester dopamine, hold dopamine in so that dopamine doesn't get released out to the synaptic cleft and cause damage. As you can see here, the level of the VMAT2, the levels are down in the compulsive and the non-compulsive rats. So again, if you expose, even if you don't meet criteria for DSM, the meth use disorder, if you're exposed to the drug long enough, high enough level, you're impacting your vesicular transporter. And the dopamine transporter was also down, just like Dr. Volkow showed in her human studies. And we did some study with the dopamine D1 type and D2 type receptors, and they were all over the place, and we couldn't really explain the study, so I won't bother with them. Next slide, please. And then, so this is a summary slide of what happened in the dopamine system. In the compulsive animals, we saw decrease in the dopamine transporter. We saw decreases in the VMAT, and we saw some changes in the various receptors. And the reason why all of these toxic mechanisms were happening is because dopamine was being transformed to quinones, and the quinones would cause generation of superoxide radical, hydroxyl radical. And that's why I'm saying to you, if you have patients who are using this drug, you need to give them combination of antioxidant, including vitamin E and glutathione, and that might be helpful to their brains. So let's talk a little bit now about the epigenetic changes that can happen, but in the nucleus accumbens. And we did the same thing. We trained the animals to give themselves methamphetamine. We go through this shock phase. We separated the animals into addicted rats and non-addicted rats. And those are the figures representing, showing that the rats will take a lot of methamphetamine, right? So when you look at all the rats before we do the shock, you cannot differentiate between them, right? So if you were to euthanize the rats after 20 days and make up hypothesis about addiction, which is what a lot of basic scientists do, they make hypotheses based on all of the rats, all the monkeys. They don't go through this differentiation of the animals, but hypotheses that are based on the, after you go through the adverse consequences, are more likely to help us develop better treatment. So in my lab, we've developed this idea that when people, rats, and other anybody get exposed to drug, there are individual factors, right? You all know this, that they are, hopefully you live a good life when you were in college, were exposed to people who took drugs, including marijuana or alcohol, who never really developed addiction. But there were also some of our friends who did become addicted to drugs. And then some of them, their lives completely got disrupted. So there are individual factors that really help people be resilient or susceptible to becoming addicted to a drug. And that is dependent on the environment where they live, and there are changes, different changes in gene expression, okay? And also, because changes in gene expression would only explain, say, acute, short-term changes, we decided that it's more likely that's why you have this bigger error, is differential epigenetic alterations are the one that keep people addicted for a long period of time. And we need to be able to attack these changes to help people get better. And then obviously some people are resilient, like this. Those are the non-compulsive rats in the presence of food shock, and others meet criteria for substance use disorder. And depending on all of these factors also, some people you have in treatment, they do well, others not so well. So in terms of epigenetic changes, by now you've read that schizophrenia, manic depressive illness, anxiety disorders, they all have epigenetic changes when people study post-mortem, and even in the peripheral blood. So you have DNA modifications that include DNA methylation, DNA hydroxymethylation, and some other DNA changes. But you also have histone modification that include acetylation, methylation, phosphorylation, and ubiquitination. In our lab, we mostly study DNA methylation and DNA hydroxymethylation, and histone acetylation and methylation. Now, because several groups have shown, mostly from Johns Hopkins, have shown that DNA methylation, hydroxymethylation is important for cognition and synaptic plasticity, so we wanted to know what happens in the brain of these animals whose behavior I just showed you. And we did that by using the last thing, where we do genome-wide sequencing. So instead of using hypothesis-driven ideas, we look genome-wide to say, okay, what's going on in the brain? Next, please. We use the nucleus accumbens this time because we euthanized the animals 2 hours really early on during the process, and look at the number of changes that happen in the brain. As you can see here, those are a lot big numbers. If we compare the compulsive rat, the non-addicted rat, to the non-addicted rats, you see a lot of DNA hydroxymethylation peaks, right? So they were all exposed to methamphetamine. But then when they were exposed to food shock, there was the separation. So even though they were all exposed to methamphetamine, there were these differences between the two groups. That told us immediately that you cannot use the brain of all the animals to look for ideas about how to approach treatment. So what we've also found was that a lot of potassium channels were impacted in these animals, right? And you probably don't remember about potassium channels, but potassium channels, they're very important to get the action potential back to normal. They're the ones that are important for that. When you look at I don't have a blackboard, but when you look at the potassium channel, it always goes up, and then it goes down below, and then it goes back to up to the line. Potassium channels are important for that deep that you see in the action potential. And so we say, oh, wow, that's really interesting. That's important. And then so there's a program, we put all of the genes in the program and see what happens. And as you can see here, the potassium channels are important for transport of molecule. they're important for cognition, which is, we got very excited about that, and they're important for synaptic long-term depression and Krebs signaling in neurons. And then, in addition to looking at DNA hydroxymethylation, we measure the expression of the potassium channels in the brain of these animals. And as you can see here, in most all of the potassium channels, expression were increased in the animals that were not addicted, right? This is as if when the animals suppress, the reason why the animals were suppressing their intake when facing food shock is because of the increase in the expression of potassium channel that was reducing the ability to press for methamphetamine. So this is a summary of what I just said. Next. So I'm going to probably stop at this slide so that you can ask questions. So what I've been trying to tell you is that upon methamphetamine exposure, there are individual factors that whose genome, those people, their genome impacted, and they had transcriptional changes. And then some of the genes that I didn't talk to you about were related to stress nuclear gene and mitochondrial genes, right? Those are also impacted in schizophrenia, okay? But importantly, there were these epigenomic changes, right? And in this case, I presented data on DNA hydroxymethylation. And we know now that DNA hydroxymethylation is important for cognition, and we know that patients who suffer from methamphetamine use disorders have cognitive abnormalities. They have bad memories. So when you're going to treat these patients, you need to keep that in mind. Not just the fact that they're using drugs, but this other aspect of drug addiction that can lead them to go back to using the drugs. So, and at the bottom, and I now no longer think of addiction as a drug-taking behavior problem. It's not. It's really related to changes in the synaptic mechanism, and it's related to memory cognitive dysfunction that I've published papers about cocaine, marijuana users, MDMA users. They all seem to have cognitive deficits that might impact how they do in treatment. So, you know, a lot of people think, oh, wow, these people are so delinquent, they won't come back. No, think in terms of what else is going on cognitively with the patients so that you can address that when you have them in treatment. So I have some clinically relevant summaries. Let's go through that quickly because we still have some time. Controversies, patients do develop Parkinsonism later on. Next, why people use drugs. It's very attractive, easy, inexpensive, long-lasting effect. I showed you that curve. A lot of different ways to take the drug. And then, so people use drugs because it makes them feel high, but really that's really more at the beginning. But the drugs have a lot of medical, neurological, and psychiatric complication, and then you need to keep that in mind when you see your patients. And those are the people in my lab that participate in some of those studies. I don't have the long list of the people that I've had, people like listing the past 20 years. I only list people who are presently working with me. Thank you very much. Thank you for listening.
Thank you so much. So now is a time for any of you in the room or any of you Zooming in virtually to the live stream to ask questions. I will start with questions. So if, based on your research and your body of research, if you had to design a drug to help patients with methamphetamine use disorder, where would you start looking?
Okay, so I think based on what we've done, we're doing a basic science study now looking at potassium channels. So we're going to give potassium channel agonist And I think those are really important because it really showed up very nicely. So at the end of the study, we look up potassium channel, and there are some people who have actually used them in animal studies for alcohol. It's also activating those channels, also suppress alcohol intake. So we're doing this basic science study, and then if that works, we're going to go to humans almost immediately to try, because they're clinically available, right? Yeah. They're being used for neurological disorders, and they're FDA approved. So I would go potassium channel. Then the second thing is, I believe in polypharmacy in some cases, is take care of the cognitive dysfunctions that all of these patients have, right? So you need to have a treatment program, you need to have a neuropsychologist evaluate the patients before you put them in treatment, and identify the ones that have cognitive deficits so that you can address it, and then come up with a medication that would, and then you can do that different ways. You can do it with medication, you can do it by cognitive rehabilitation, right? But, and then the potassium channel. So there would be drug to treat cognition, drug to suppress drug-taking behavior. That's the way I would do it. And I don't think one drug's going to do it. Right. I think we probably need at least 2 drugs to address these patients. Every time people have tried to use one drug, you know it. It just doesn't work. And it's because they're addressing the drug-taking behavior, but they're not addressing the brain disorder part of addiction.
Right. Right. Yeah, I mean, it's a big misnomer, I think, that we call these behavioral disorders. They're brain disorders.
They are brain disorders. Right? There's no question in my mind. Yes.
A lot of our present antidepressants boost serotonin. They boost dopamine effects. What impact do those medications have on somebody's users?
So some of the drugs, I mean, most of the drugs work on the norepinephrine system and serotonin system. And the impact on dopamine levels in the synaptic cleft is much less, right? But the ones that impact norepinephrine and dopamine, like mazendol, for example, they have not been shown to be really good, like in basic science studies, and clinically, they haven't seen much success. I mean, people have tried the antidepressant in meth users; they just don't work. And so it's really because the disorder is an epigenetic disease. And as you can see here, the potassium channels are involved. So we need to stop thinking of beyond the noradrenergic, dopaminergic, epigenetic system to think, okay, what are the epigenetic changes that cause these long-lasting disorders, and how can we impact the epigenetic changes so that we can bring the back to a homeostasis and go from there. But importantly, like I mentioned before, you have to keep track of the cognitive disorder aspect of substance use disorders.
Okay, so we have a couple questions from the people who are on Zoom. Are the synaptic function changes permanent, or can they self-correct after cessation of use?
Okay, yeah, that's a really very important question. I think from what we wrote a paper with this Japanese group in like 1998. Looking at the brain of patients who've been withdrawn from methamphetamine for 2 years. They still had abnormalities 2 years out, right? That's why I keep on saying there need to be medications that address this dysfunction that might be long-lasting. We need to think of the disorder as a brain disorder, and that the impact of the methamphetamine and on dopamine system, on serotonin system, on epigenetic system, and it seemed to be, we've seen this large number of genes that are impacted. So we need to try to figure out how to develop a pharmacological approach that addresses all of the, if not all, but many of the changes that we're seeing when people are using these drugs.
Right. I have another question from the virtual world. Can a person using meth who has PTSD due to combat experiences ever have successful treatment for the changes in the brain causing harmful behavior?
Wow, that's a really tough question. So they have PTSD, which is actually, there are a lot of studies now showing that PTSD brains are impacted epigenetically. Okay, so there's data about that, and there are a lot of data on stress causing. And I wrote a review paper in 2016 about the epigenetic of stress, addiction, and the similarity between these. So you have some similarities between PTSD brain changes, which is PTSD is also a brain disorder, right? Mm. So we have this brain disorder called PTSD, and then we have this methamphetamine-induced changes in the brain. So that gets very, very, very complicated. And we haven't done enough studies in a model of PTSD with methamphetamine on board for me to actually come up with a really good answer to that really important question. But I think in both cases, if you could identify the overlap between PTSD and meth use disorder, you could address that overlap, right? So you have the Venn diagram, what's going on inside the overlap, and then a push dose, but not enough data to answer that question. But it's a great question. Okay.
I have about 5 more questions. I'm going to keep it to 2 or 3.
Okay.
One related to comorbidities. We see both psychiatric and medical, but I'll start with the psychiatric. We see a lot of comorbid major depressive disorder, PTSD, methamphetamine use disorder, and anorexia or bulimia. And when you think about, I'm particularly thinking about your slides showing the importance of the upward projection from the substantia nigra pars compacta to the dorsal striatum. Mm-hmm. What is the, molecular neurochemistry in that projection? Okay.
So that's a very, very good question. So all of the diseases that you mentioned, right? If you think in terms of circuit, right? They all seem to involve the VTA and also the habitual, right? So both the projections from the VTA that are more multiple, more numerous than the projection of the dorsal striatum. So we have a study right now that we've just finished writing, looking at both gene expression and epigenetic changes in the dorsal striatum of methamphetamine use disorder patients. What we've identified is that there are also potassium channel related changes in the dorsal striatum. So the study I showed you was the nucleus accumbens. So the results we just finished writing is the dorsal striatum. So the potassium channel seemed to be dysregulated, not only in the nucleus accumbens, but also in the dorsal striatum. So if you could project to other diseases, like anorexia nervosa is very important in terms of the use of methamphetamine, right? So people who use methamphetamine, they have decreased appetite, they don't eat, and they're anorectic. So the circuits might be similar, okay? So the question is, okay, what can you learn from methamphetamine use disorder in terms of the connection, in terms of appetite regulation, and say, okay, those might be impacted in some of the diseases. But so, because I didn't know you were going to ask this question, but what we're doing right now, I have a postbac who's using a technician, and then we've identified many genes that are important for appetite regulation, and we're measuring their expression in the animal model that I showed you. We're looking at the prefrontal cortex, we're looking at the nucleus accumbens, we're looking at the dorsal striatum and the hippocampus. So what we're finding is that there are more changes in the hippocampus and the dorsal striatum than there are. I actually was predicting that there would be larger changes in the prefrontal cortex because of decision making, things like this. It didn't turn out that way. So the dorsal striatum and the hippocampus are the places. So it seemed to be there's some cognition related changes in genes related to anorexia, appetite regulation. Yeah.
Awesome. That's really cool.
Yes.
Thank you so much. You mentioned that all the typical antidepressants that we use are not really helpful for people with methamphetamine use disorder. Is that as true when they first get sober as it is maybe like 5 or 10 years sober, that they still wouldn't work?
Right. That's a good question. Really important question. Okay. You remember at the beginning of my talk, I said that actually, maybe 10 minutes within the talk, I have that slide. That's our drug exposure, escalation, and then we have the binges and the cycle. I think it's really important, but people haven't done those studies, right? So when the patients come in, they withdraw them briefly from methamphetamine, right? They study, and then they put them on antidepressant almost immediately, right? And then they follow them, and these people relapse. Right? So you never really had time. There's no differentiation. Okay, I'm going to let this person clean up get their dopamine level back to normal, their serotonin level normal, their norepinephrine normal, and now I'm going to treat them with this antidepressant and see how they did. Right? People almost always, in all of the studies that I've read anyway, there might be others, okay, they come in, 2 days later, they are on pharmacological treatment. Yeah. So that doesn't work for me. And I don't think we should do that with patients. We should really get the drugs out of their system. You put the antidepressant, the methamphetamine half-life is long half-life. So you're having an antidepressant interacting with the effects of methamphetamine that's still on board. So it's not really, those studies that you want have not been done that I'm aware of.
Yeah.
Is there any sense of how long you should wait to have somebody off?
I think, for methamphetamine, a week is good enough to get rid of the methamphetamine from their brain. But the brain changes are still there. But it's what I'm saying is that if you have amphetamine in the brain causing changes, and then you add something else that causing even more changes, you're not going to be able to cleanly decipher what's going on, right? But the brain changes are there. I mean, you remember I mentioned 2 years later, we still were seeing these changes in the brain. They were Japanese patients, and then those guys wanted to see what ideas I had about how to explain it. So the paper's been quoted quite a bit, so I guess some of the ideas suggested were not bad. But yeah, I mean, it's the brain changes are important, and they're not going to go away after 1 week, but the drug is not going to be there. For marijuana, though, marijuana can last for a long time in the brain, right? And we published studies in collaboration with some NIDA people who, she's no longer there now, but like even after like 2 or 3 weeks, we can measure marijuana metabolites of it. But you don't do that with methamphetamine. By a week, you cannot measure the level.
I have a question about medical comorbidity. Mm-hmm. I'll use a clinical example. Oftentimes we'll see people with histories of multiple substance use disorder, including methamphetamine use mm-hmm. disorder, who in their first 3 months of abstinence go to neurologists, get diagnoses of narcolepsy, And that's a comorbid condition that we see often. And I wonder how much of the narcolepsy is true narcolepsy versus how much of this is the person was tested, either while they were still using methamphetamine and on a crash,
Crash. Yeah, I
versus
think
how much is true.
Yeah, I think those, as you saw in the list of of conditions that methamphetamine was used for, narcolepsy was one of them, right? And I don't think we should do that anymore. But so if during the crash, so you have compensatory mechanism that could lead to narcolepsy. So any diagnosis post methamphetamine withdrawal that you see would be very suspicious, right?
Right.
So we'd have to wait and actually make a real diagnosis after the patients have been off drug for a while before actually coming up with a real diagnosis. But at the same time, though, you have to go back, take a good good neuropsychiatric history, good neurological history to see if the person, maybe they were treating themselves with methamphetamine because they had narcolepsy,
yeah.
right? So they had narcolepsy, they treated themselves, they become addicted, and now they're withdrawn, and so the narcolepsy comes back.
The other medical comorbidity I wanted to ask about was Parkinsonism or Parkinson's disease.
Well,
we
it's
have
really-
young people who have been diagnosed with Parkinson's disease.
Yeah, it's not really Parkinson's disease in those cases. That's why I call it Parkinsonism, right? On my slide, you don't see Parkinson's disease, right? You see Parkinsonism.
Right.
So they have the clinical manifestation of what is Parkinson's disease, but it's not idiopathic. I think it's related to the toxin. Methamphetamine is a drug of abuse, which is a toxin.
Right.
Okay, it's a toxin to the dopaminergic system. So they ended up early on, especially if they were susceptible to the effects of oxidative stress, poor nutrition and all that. So their dopamine system get impacted and they suddenly look like me, they slow down and they speak slowly. So it's Parkinsonism, not Parkinson's disease.
I don't know, it might be just me, but I don't experience you as being slowed down.
You didn't know me.
I didn't know you 20 years
when
ago,
I was
though.
like,
I have no baseline.
my mother always complained.
For those of you on Zoom, follow the link that should be on your screen, on your Zoom screen right now, to obtain your CME or CE certificate. Thank you all again very much for coming, and we look forward to hopefully having as many of you back as possible next month for a talk about PTSD, eating disorders, and addiction, all comorbid.
Thank you.
Thank you very much.